please.
Can everybody mute themselves, please?
We are live, please.
A very good evening, everyone. Not only to members of the Maharashtra Ophthalmological Society, but all the other ophthalmologists who are tuning in. A very warm welcome from the Scientific Committee of MOS. Now, last year, we had a diabetic retinopathy webinar, which was extremely successful, covering a whole range of other topics on the occasion of World Diabetes Day. And similarly, celebrating this year's World Diabetes Day, we are having a diabetic retinopathy symposium, 360 degrees, which essentially is going to focus on early detection to advanced management. And this is essentially a practical symposium, which is going to be of use not just to retina surgeons, but to comprehensive ophthalmologists as well. Now, the session will be moderated along with me by the member of the scientific committee, Dr. Anil Mahindrakar. We have a wide range of expert panels, leaders in retina and ophthalmology. We have Dr. Prashant Agnihotri, a senior retina surgeon from Nagpur. Now, in view of finishing the program in time, I'm not going to go through the detailed CVs because all of them are truly leaders in their own right. We have Professor Dr. S. Natarajan, who's joining us from Bolivia. And thank you, sir, for agreeing to be a part of this. He was a part of it last year as well. And nobody needs any introduction in the retina world. Dr. Natarajan does not need any introduction in the retina world. We have Dr. Manoj Sasavade, who's going to be joining in a little late because he has an end-of case which has come in right now. We have Dr. Haresh Asnani, a senior surgeon from Navi Mumbai. We have Dr. Sharad Bhumat sir from joining us from Meerut Sangli, and Dr. Hemang Kopikar sir, who's joining us from Mumbai. So what we're going to follow is we have 8 to 10 minutes for each talk, followed by 4 to 6 minutes of discussion. We would like to hear from the expert panel on the relevant on the particular talks. So with this, we will invite the first speaker, Dr. Vatsal Parekh has some issue with his connection right now, so we'll go on to the next speaker, Dr. Divyansh Mishra, my dear colleague from Sankara in Bangalore. So please, yes, please share your screen.
Okay, hopefully my screen is
Welcome, Dr. Pramod Bende sir also. Warm welcome to one and all.
I'm so sorry, Dr. Pramod Bende sir. Of course, his name was, I don't know, somehow missed in this expert panel. Thank you. Yes,
My name is on a speaker panel, so don't worry. I am there. So thank you very much. Thank you. So
yeah, warm welcome to one and all.
thank you.
Thank you, sir.
Divyansh, can we please begin?
Sure. So hopefully my presentation is seen and I am audible too.
Your voice is a little lower on the lower side.
Okay. Is that okay?
Slightly
louder, yeah.
Yeah. So good evening all, and at the outset, I being the opening batsman. So thanks Maharashtra Ophthalmic Society and Dr. Piyush, Dr. Anirudh for giving this opportunity. So a very pertinent topic which was provided to me is Opta and DR, a non-invasive and yet uncompromising. So let's dive into the topic. So let's go according to the case scenario. Let's see, the first case is a routine case of a diabetic retinopathy, which had severe kind of diabetic retinopathy changes, as we can see, was under routine follow-up for 2 years and did not had any recurrence for CME. The right eye was post-vitrectomized for ERM with CME. But suddenly, after around 2 to 3 years, what we can see is that there is kind of a abnormal blood vessels which have developed on the superior temporal arcade, and there is some kind of an heart exudate and a macular edema which has kind of. So as the patient was on a routine follow-up, we had all the serial scans and we reviewed that, and there were not this kind of an abnormal blood vessels. So what the easiest investigation which we can have in our armamentarium as a retina specialist is an OCTA, or an optical coherence tomography angiography, where it's a dieless kind of an angiography where just by some kind of a digital subtraction, we are able to see the blood vessels. Very important to understand, this is a superficial network, what we can see. But the OCT-B scan is suggesting that the blood vessels are not above the island. What does that mean? So if the neovascularization has to develop, it has to cross the island and go into the vitreous cavity. So in this case, we can see that all the blood vessels, whatever the abnormal vasculature is there, is intraretinal. So what we are looking at, is it really a neovascularization or is it a nirma? We did a larger or a wide field opta, which is a 12 by 12 mm, which is the machine which allows us to do it. what we can see is the larger network, but we are still not sure. As you can see, the macular edema is there to a certain extent. So we had planned for an angiography, and angiography is also suggesting that there are some abnormal vasculature with a lot of CNP areas and microorganisms. But very important point to note is that there is no or very, very minimal leakage. So what are we looking at is what is called as irmas. The similar kind of lesions are there in multiple places in the other eye also. And this is after anti-VEGF and tight laser. What we can see is complete obscuration or disappearance of those irma kind of lesions. And in between, the patient had also had a neovascularization of the iris and the glaucoma, but all that also subsided with the tight laser and anti-VEGF. This is the same segmentation what we can see pre and post treatment, where the complete obliteration of new blood vessels are seen. And the OCT, the B scan, also is showing that the vascular network which was in the intraretinal space has also near completely got obliterated. So what are neovascularization? So if we have to see a neovascularization, it should be going into the vitreous cavity. As we can see, there are different types. So they are defined, certain studies have defined as type 1, where there can be a single kind of a tree, and then there can be a kind of a branching which comes above the ILM, or kind of a shrimp kind of a lesion. The type 2, where we can see that there are like an octopus, where there is the blood vessel has multiple kind of connections, and there is neovascularization which comes into the vitreous cavity and then proliferates on the retinal surface. And the type 3 has an association of an IRMA, where the ischemia goes to an extent where the intraretinal neovascularization then breaks the ILM barrier and goes into the vitreous cavity and forms a neovascularization, which is like a C-fan. So what have we learned out of this? Very important hallmark of proliferative disease of neovascularization has to be seen at the VR interface. And yes, Octa helps us identify the neovascularization, but also IRMAs, which are in the sub-ILM or the intraretinal spaces. And the OCT-B scan or an NFAS also helps us understand very well. Let's switch on to the next scenario, which is a very pertinent kind of a presentation. Patients presenting with kind of some blackish mass or blackish kind of a pigmentary lesion at the fovea and with pre-retinal hemorrhage. So what is this? This is a case of a proliferative disease with MACTEL. So this is a very kind of a weird presentation, where there is a macular lesion, where there is a neovasculation of the disc, and there is also something which is called as ERNVM, or epiretinal neovascular membrane with intraretinal neovascularization also. So in the left eye, we have just observed, but the right eye, because that had a gross VMD, we have treated with surgery and foveal sparing ILM peeling, and this is what the pre and post-op follow-up looks like, where all the neovascularization has regressed, but in the left eye, it still remains, and we are closely observing. So to talk about what did we learn out of this case, very important, Octa is very safe and then repeatable in these cases, where you don't need to keep injecting angiography every time, and Octa would be able to help us identify the neovascularization, the regression, and also quantitative measurement after laser, whether it is progressing, worsening, or whether new lesions are coming up. And that also in a very non-invasive way. Let's switch on to the third scenario, where we may see lot of kind of dilated tortuous vessels, and there are some doubtful areas of whether this is gross neovascularization. No, this is just collaterals which occurs in cases of vein occlusion, and very important to see that we can do an Octa over the disc itself, and we can see that the lesion, all the vasculature is within the ILM or intraretinal. Yes, in certain cases you can see the neovascularization goes into the vitreous cavity, but very important to understand is the segmentation, that the top segmentation has to be as high as possible and the lowermost has to be on the ILM. As we can see in this case, the neovascularization is at the disc, which is like in heart shape. But very important to understand, we can also identify that there are a lot of areas of non-perfusion, capillary dropouts, and also abnormal vasculature. So what did we understand out of this is, in these cases of the vein occlusion, we can understand whether there is a collateral versus neovascularization, whether there is quantification of non-perfusion, and yes, very important, if there is a neovascularization which is developing either elsewhere over the disc, and that can be very easily followed up in a non-invasive way. Let's go on to this last kind of a case. In this case, what are we seeing? This is a very important case of a choroidal melanoma, which is treated by brachytherapy, which blackish color, brownish color lesion, which we are seeing just temporal to the macula. And what in the Octa, which we are seeing, is something which is called as radiation retinopathy, where there are capillary dropouts because of the radiation, and some hard exudates because of the capillary budding and formation of like a non-proliferative retinopathy, what we see in diabetes. So this is a case of a 5-year follow-up, as we can see 2017 versus 22. After the treatment, we can see that all these kind of CNP areas are remaining stable, and these kind of bulbous ends have become more well defined. So what did we learn out of this? Very important that OCTA is a non-invasive modality where it can help us identify the capillary dropouts or understand even the destruction of the FAZ if it's involving the macula, like in the second case, and show the reduced vascularity, retinal thinning, and vascular remodeling. Let's understand if there are study-based insights. What does the study suggest? So on the left-hand side, we can see is a normal healthy adult. The second column we can see is a diabetic with no retinopathy. The third column is showing mild retinopathy, and the left is a very severe kind of a retinopathy. What we are able to see is the non-perfusion. So if we are able to perform a 12 by 12 octa, we would be able to identify with very high sensitivity and specificity occurrence and also kind to say progression of diabetic retinopathy. Let's talk about what are different types of OCTA which are available with us. So very important, there are single shot wide field octa which can be either 12 by 12 or 15 by 9 depending which machine do you have. But yes, there are certain modifications which you can also do it by do it yourself, like in EFI or extended wide field or the innovative wide field which we had published long time back in 2018. And the last but not the least, the montage technique. Let's read about each and every one a little kind of. So what we are understanding in this is a small scan shows a good quality posterior segment, but a larger scan has lot of information, but very important to look for different changes also. To talk about whether a small scan versus large scan, the smaller scan has a very high diagnostic performance, but the wider scans are associated with lot of artifacts. But yes, lot of information which can be utilized to understand whether the neovascularization or the capillary dropouts are there. So this is the technique of EFI where the 20 diopter lens is worn on a optical this thing, and then you can do an OCT. It increases 30 degrees of field, as we can see. If you're doing a 12 by 12, we can actually go up to 55 degrees, as what you can see. What we also did in this case is, rather than using not only the lens, but using the 78 diopter slit lamp biomicroscopy lens, and we were able to do as wide as 20 mm of OCTA just with your available scan itself. How does a montage technique works is it you can montage multiple kind of 4 by 4 3 by 3 scans and then make like this wide field kind of an OCT. But there is an issue. Not 1 plus 1 is equal to 2. As we can see, as and as we go into the periphery, the retina becomes thinner, so that the segmentation also keeps changing. As you can see, actually in the periphery, the intermediate zone or the middle layers of the retina becomes very thin, and that becomes an issue. So if you have the newer prototype kind of machines, you can get such wide field octa which are very beautiful. So you can see wide field OCTA where there are multiple capillary dropouts with new vascularization. This is kind of a patient where they had followed up association of non-perfusion areas which didn't increase at 1 year follow-up. In this case, they had done, they couldn't do an FFA because the patient was having some nephropathy, but the neovascularization did not regress after the laser. In this case, they have done the octa pre and post laser and shows very well regression at 1 month. So yes, once you have done such a wide field and OCT, that can be utilized for other studies like binarization, vascular density, and other things and like that. But yes, OCT does not come with or it's not everything hunky dory. It comes with its own problems, which are called as artifacts. As you can see, multiple different types. So I would just keep mentioning because I cannot go in each and every detail. Motion artifacts, or either poor quality octa because of either poor fixation or cataract, or SSPM, or a suspended scattering particle in motion, where it may give like in hyperreflectivity where actually there is no neovascularization. Projection artifacts where the major blood vessels cast its shadow onto the deeper layers, which it can still be seen. Blink artifacts or vitreous opacities, like in cases of asteroid or dense vitreous kind of opacities, which can be missed with non-perfusions. False friend. So if there is a very high reflective structure like a PED, the RP can show like a kind of a hyperreflective structure in the octa, but actually this is no neovascularization. Sometimes FFA does not show any perfusion, but octa can, because it depends on the flow, what it is detecting. And because it's the flattening of the periphery, actually there is overestimation of the neovascularization. Octa, everything is black and white. It is very dull. But FFA, it just burns, or it's like a light bulb where you are able to see all the abnormal vascularization. The new blood vessels are very easily able to find out, but yes, the posterior pole lesions, it's better to do a smaller scans. You may see a lot of like eyelashes, motion artifacts. The larger the scan, the larger the motion artifacts. If the pupillary dilatation is poor, the artifacts would be more. If the fixation is different, you may see a different angle of blood vessels. There are multiple other flaws. Going on to the last but not the least, which is the newer advances. So actually, Opta is like a compressed image or a three-dimensional image projected as a two-dimension, but not. The disease is three-dimensional. As we can see, actually the neovascular or the micronerisms are not just a dilatation, but those are like saccules which have multiple connections in the various layers of the retina. That's what the studies have suggested. And yes, there are microaneurysms and mini aneurysms which occurs in multiple layers also. This is right now, there are multiple works which are going on the 3D Octa. So last slide, which is the take-home message, Octa helps in diagnosis and management of multiple chorioretinal pathologies. Wider Octa has multiple advantages, but yes, there are a lot of disadvantages also, as I had suggested. Advantages, better segmentation and software, and more advances would be in cases of better segmentation softwares which are available in certain prototype machines, better technology in the scan acquisition, and 3D Opta, as I was suggesting. So again, thank you all, and wishing you all happy Men's Day for today. So we are open for discussion.
So thank you, Dr. Divyansh, for a very comprehensive overlook. What I would request is regarding the discussion for the same, let's stick to diabetic retinopathy rather than the whole gamut of retinal diseases. Now, I would like to ask you with regards to Octa biomarkers, which ones do you find the most predictive for progression from NPDR to PDR?
So as we were discussing, the non-perfusion areas are the very important things, which we can see that from starting from non-proliferative disease to a proliferative disease, it's the progression of the non-perfusion areas. And very important is the non-perfusion areas which
Can you hear me?
We can
Yes,
hear
sir, Dr. Batsal, we can hear you. I'm just muting you for a minute. Can you switch off the camera on the mobile, please?
Yeah.
Yes, please go ahead.
As we were discussing, so the CNP areas, and more importantly, the neovascularization occurs in the venous side of the CNP areas, which we are seeing. Yes, in an Octa, it's difficult to make out what is venous and what is arterial, but there are newer studies which have suggested the CNP areas, the area, or the more the CNP, the more is the chance of neovascularization. So I would say the CNP or the non-perfusion.
Thank you. So I would like to ask our esteemed panel, do you think that as of now, Octa can replace FFA in at least certain situations or decisions that we are making, or is it just a complementary tool?
I personally feel that Octa is a very invaluable tool for us because it's non-invasive. That's the most important part of it, and especially in conditions where we cannot use fluorescein or whatever dyes we want to use. However, still 10% of the cases, I think fluorescein gives you more information. I mean, that's what is my personal opinion. That I would prefer doing a fluorescein in these cases where I really want to know the location and the new vascularization, whether really it has crossed the ILM. I don't know how far Octa will be able to define that.
I also agree with Dr. Prashant, and I think that basically a very thorough clinical examination with a contact lens on the slit lamp, followed by, if required, a FFA, and you have to see the periphery very clearly, and you have to find out what is the amount of non-perfusion or whatever lesions are in the periphery. And when one elects to do PRP, as I always say, you must do, when there is proliferation, you should do a complete PRP as the standard thing.
No, I think I agree with Dr. Prashant about the need for FFA in still a small percentage of cases, especially with the fact that we've been doing FFA for so many years, and even now we are more familiar with all the nuances of fluorescein angiography and its markers or findings compared to OCTA, which we are still in the learning process.
I think that global ischemia, global retinal ischemia is something we have to assess, and that judgment can be given by FFA. Focal ischemia, yes. Focal lesions, yes. But if you are looking at the whole retina as a whole, probably I would always have Octa as the backup for me. Local focal lesions, yes, Octa does help. But when you're
Yeah.
talking about the whole retina as an ischemic area, then we can judge and take the treatment forward. That's my opinion.
Yeah, I think I agree with Prashant, and I think 10% of the patients with multiple medical problem
True.
with renal failure, those patients we depend on OCTA, and I think as Devansh presented well, we have to use our clinical examination and OCTA wisely in where you can't do the FFA. Wherever you can do FFA, it's fine. But and I think they have allergy, so I think that's where only FFA, where OCTA we have to keep learning more so that one day it may replace FFA.
I think should we go to the next talk?
Any other question or any expert panel would like to share? Or I would just throw the ball in the expert panel's court. This is a very important topic, of course. So we'll just take another 2 minutes. Because there are some limitations that I feel that which are there when we are interpreting deep plexus changes in diabetic retinopathy. So if you all have any experience regarding that, and also is it that assessing macular perfusion in eyes with, especially when there's media opacity, fixation instability. So how reliable is Octa over there? So briefly, if somebody would like to address this.
Well, that's always a challenge. Piyush, that if there's a media opacity, I have my own doubts whether Octa will be of a very big league. Here, at least with an FFA, we get a gross idea that this much of ischemia is there. Octa is only you have to have I think what
let's move on to the next one.
Has done a great job by this presentation, that he has given us quite clear ideas about actual use of Octa, where what is to derive the impressions from. Divas, thank you so much.
Thank you again. It's a pleasure.
Dr. Vatsal sir, are you ready?
Yeah, let's go for the Vatsal's talk now.
Dr. Vatsal, please unmute yourself on the device. You are muted, please.
Yeah, you're muted.
Yeah, can you hear me now?
We can
Yes,
hear you,
sir.
sir.
Yeah.
Can you hear me?
Yes,
Yes,
we
sir,
can
Yes,
yes.
Dr.
hear you,
Vatsal,
Yeah,
we can
can
hear
you see
you.
my slides?
Yes, sir. Yes.
So good evening, everyone. I'm sorry, Piyush. I thought I have the most advanced instruments. I am most advanced, but I'm failing in presenting in webinar. Thanks for everything. So can I start presentation?
Yes, please do.
Yes, sir, please.
So the topic is ultra wide field image in diabetic retinopathy. Does wider mean wiser? Now let's see what I have to present in this. Now this is a patient who has fundus photograph you are seeing in the top slide, and the same patient's wide angle view in the bottom slide. Now this is the view difference in ultra wide field. You can see up to 82 degree of retina in single view. Now why wider is wiser? Because it gives you early diagnosis, and peripheral lesions are seen much more with this ultra wide field screening. Risk stratification, since you are seeing more of the disease process, topography is better. Treatment planning is better. We'll just see that how it helps that. Screening intervals can be decided by better planning the disease stage. Targeted laser therapy is possible, and telemedicine is also possible because you need not have ophthalmologist to take photographs. So lesions could be central plus peripheral or predominantly peripheral. You can quantify peripheral lesions and non-perfusion areas. Again, ultra-wide field technology will help in special situations like small pupil and media haze. What I intend to do is show you 4-5 cases of this. As I told you, as I showed you the photograph, 45-degree camera view is usually 15% of retina is seen, whereas here you can see 82% of retina in one go. And with montage, you may be able to see up to 100% retina. When you are able to detect peripheral lesions earlier, the risk of progression is 3.2-fold more in eyes with NPDR and 4.7-fold more in eyes with PDR. So you can pick up this early. Now, DME may be associated with peripheral non-perfusion. So, fluorescein angiography could be dye-based or OCTA. I'm going to show you dye-based angiography. Now, this is first patient where you see on OCT, there are a lot of cystic spaces in the right eye and left eye. Autofluorescence does not reveal much. And fundus photograph here does not reveal much of the changes. If you see, these are some of artifacts on the camera lens. But if you see, the retina does not show much of changes. So you are wondering whether this is any other cause of cystoid macular edema. But when you do ultra wide field angiography, you see the non-perfusion in these areas with leakage. There is cystoid macular edema. If you see this photograph and this photograph, and also there is this stain, so there is diagnosis is proliferative diabetic retinopathy with diabetic macular edema. The same way the other eye shows the changes of proliferative ischemic retina with leakage. So if you go back to the fundus photograph, this was ischemic retina, which was featureless. So this technology will help you to detect. Now on OCTA, you will not see leakage, but here you see leakage. The good use of this technology is this patient who has glaucomatous optic atrophy in right eye, no perception of light, left eye is vitreous hemorrhage with not good view, but whatever retina you are seeing in both eyes is quite looking normal. So whether this is PVD causing vitreous hemorrhage, whether this is vein occlusion, diabetic retinopathy, you don't know. But when you do angiography, since this is ultra wide field angiography, even with this hemorrhage, you can see this is the disc area, this is the macular area, and these are new vessels, and there is some amount of disc stain. So you know for diagnosis that this patient has proliferative diabetic retinopathy, and you need not worry about retinal PVD and retinal tear, and you can give injection and laser much earlier. Now the next case, again, similar way, you see probably some disc hemorrhage here. These are cataractous haze. Vision is 6, 9, and 6. If you see OCT, there is some amount of tractional macular edema here. Now, since there's a small view, you can magnify and you can see that this is the traction what you saw. And this is the hemorrhage. On magnification, you can see this pathology much more. And when you do angiography, you see the disc click here and macular edema, which is because of the tractional element. So again, the use of instruments, technology helps again in the left eye. There are new vessels elsewhere. And when you saw the fundus photograph, you didn't feel much of diabetic retinopathy. So it picks up much earlier. Again, ultra wide field OCTA also would help in many of these situations. Now, this is a patient who had undergone vitrectomy, right eye. This is the left eye, which has vitreous hemorrhage. And if you see left eye view is hazy because of the edema and vitreous hemorrhage, the view is hazy on OCT also. Now, this is the FFA of the right eye, laser marks and staining from the fibrous proliferation. He has undergone vitrectomy. This is a left eye with vitreous hemorrhage. You can see that the new vessels are here. And again, you can make out that this is because of diabetic retinopathy. This was the picture in 2021 when right eye was operated with fractional detachment and left eye was much better and he was ablated that time in left eye. Now, this is in 2021 pre-op. This was the picture. And this was the leakage in 2021 from the right eye proliferation. Now, and this is the picture of right eye in 21, and this is the picture of right eye in 25. Before operation, you can see a lot of leakages from the disc fibrous proliferation. In 2025, you can see all this has been delineated well. In 2021, left eye, this was the area of non-perfusion. Here it has increased in 25, and there are disc new vessels elsewhere, and you would need more laser treatment after intravitreal injection. So again, this is 21 and 25 left eye picture. The non-perfusion has increased compared to 2021. So this helps in documenting it better. Now, this is a patient who has undergone Zeltrep injection. This is pre-Zeltrep, and this is in between December and March. She has undergone 2 Zeltrep injection, and this is August. There was 1 Zeltrep injection. Now, if you see this OCT, this is prior to Zeltrep injection. There is cystoid macular edema and fluid here. After 2 Zeltrep injection, the fluid had resolved and it looked normal. And here again, After 3 months of Zeltrep injection, you can see the edema appearing again. But what is more interesting to see in this patient is the angiogram we had done to see what is the effect. Now, this is the first angiogram which shows a lot of non-perfusion. This is the angiogram after 2 Zeltrep injection where you see the perfusion is better. This is the leakage has reduced. This is initial phase. This is late phase. This is after 2 Zeltrep injection. You can see that the perfusion has improved and leakage has reduced. And this is after 3 months of second injection. You can see 3 months of this injection. You can see again the perfusion has become bad and edema has come up. So again, it shows that even Zeltrep can improve perfusion, but again, once the effect wears off, the perfusion becomes less and you need to treat. Similarly, this is the other eye of the same patient, but here this was 2 injections were given in between December and March, and somewhere in July, and I had given Orocort here with Zeltrep injection. Now, if you see the OCT here, initially there was fluid and edema. After 2 injections, no edema. Here again, after Zeltra, this Orocort injection, there is no edema. But if you see the angiogram, here there is non-perfusion. Here there is well perfused. Here though there is non-perfusion compared to this photograph. But because of the steroid, edema has disappeared. Again, it shows that steroids can be effective in this disease. Now, we have found intelligent use of this angiography in PDR patients before surgery. This was a one-eyed patient. You can see there is perfusion is quite bad in the left eye macula. This is pre and post. And this is another one-eyed patient where there is a normal macular perfusion comparatively pre and last phase of angiogram. And this is the pre and post-op picture of the first patient where macular perfusion was poor. There was a lot of scarring. She underwent 3 surgery, but visual acuity was counting finger at 3 feet. It was less primarily because of the initial less macular perfusion and also because of repeated surgery scarring at the retina. Whereas this patient also underwent 3 surgeries. This was another one-eyed patient, but recovered 612 and 8 vision. And if you see, the initial perfusion of the macula was good prior to operation. So to summarize, I think smart use of technology aids in early diagnosis and efficient management strategies. Thank you for patient hearing, and sorry I was not prepared to present initially. Thank you.
Thanks, sir.
Go ahead, Anirudh.
Maybe you say you are mute. Thanks, sir. That
Yeah,
was
thank
really
you.
wonderful talk. I think, sir, only one question that I will like to ask, because we have mostly general ophthalmologists.
Right.
So, is there any, because most of them will not have this ultra wide field. So what should they look for, and how and when should they like red flag so that they can refer to you for a peripheral angiography, because that is what we need to tell them.
So basically, I think a good indirect ophthalmoscopy and good slit lamp biomicroscopy is a must, to dilate this patient is second important thing. And to look beyond disc and macula is important, and to look at the periphery. Many of these lesions, you can see retinal hemorrhages, proliferation. Many times I feel that when we are seeing patient, our mind is elsewhere, so it does not record or register what we are seeing. Whereas the camera records whatever is seen because it does not have mind. So when you go back to the images, you can see what you have missed, So I think giving proper attention to when you are examining patient is important. Looking in periphery is important. I was discussing with somebody yesterday that when we started practice 35 years back, angiography was only thing. Then came OCT, so angiography was forgotten art. Then came OCT angio, so macula we could see, and now since Prashant also has the same machine, ultra wide field OCT angio is a thing which is very important to understand the disease process and thing, So red flag would be any patient who has vitreous hemorrhage, patient who has macular edema, patient who has proliferative diabetic retinopathy. I think it is worthwhile doing OCT A if possible, especially wide angle. Because with normal OCT, what you get, you see only limited view of the macula, which does not represent periphery at all,
Perfect. I think what Vatsal said makes a big sense. I personally, because I'm using these machines, and I personally feel that you treat the patients. You have to really evaluate each patient with all its limitations. All these machines, they add on to the, to explain to the patient that, see, this is what has been there before, and this has been post treatment, and this has been post laser and post surgery. So probably these machines have a role, very important role, in convincing patients that what we are doing is evidence based medicine. The evidence based medicine comes very important because of all the issues which are associated with this.
Okay,
So
sir.
I think
Yeah,
this
Understood.
compliance.
One quick question, and then we'll move on to the next talk. I would like to ask some of our other expert panels who've not spoken. Now, see, excellent video, excellent pictures that and cases that Vatsal sir has shown, and we all like to see these ultra wide field images. But of course, it comes with its own additional cost. So, how often do you actually see peripheral lesions being detected on UWF? And that has actually changed your management plan as compared to standard, say, ETDRS fields or your indirect ophthalmoscopy?
I think very occasionally, it's not routinely. Personally, I think these are only adding on to our assessment of a patient's global ischemia. As always, I call it, if you have an ischemia which is running into the periphery, yes, we must treat them extensively or sparingly. It depends on the lesions.
So is it value for money in short?
It is not. It is an add-on. I mean, I don't think that it is essential, but it is an add-on. If you can afford it, yes, go for it. It is something which adds on value to your treatment. Like you say, when you look at the patient, you can tell them, and your juniors can explain to them that this is the lesions, and we are treating it, and they have been treated. Probably that evidence is very important.
Can I add
If I
something?
can
Yeah, I think.
add, just sorry,
Yes,
Yes, sir,
Pramod, go
Dr.
ahead.
Pramod, sir.
Pramod, what's
Yeah,
your
no,
Go ahead.
I totally agree because with the current scenario, documentation also equally important. It's a
very
good
important?
teaching aid, and definitely it adds on what you rightly mentioned, peripheral lesion, which generally we miss. We can have it, but yes, there are enough studies like having a peripheral CNP areas and correlating with a macular edema, and because of non-responding macular edema, and people are tried, but there's contradicting reports are there to do peripheral laser, which is missed earlier, and that will help in a settling down macular edema. I think there's still not a concrete evidence. So yes, it's nice to have it, but it's
Yeah,
not absolute must.
So my follow-up question to
If I
that is
can
that
add,
you have
Piyush,
so my follow-up
if
question
I
to what PB sir has just said is with regards to treatment based on peripheral ischemia. Of course, we detected with UWF. Uh, is it improving long-term outcome? Do we have evidence regarding that, or you think it is still inconclusive?
we don't have a data regarding that. I mean, unless we have a control data, we cannot really comment on this. That we have an evidence. But yes, it
Piyush,
helps.
can I add?
In
Yes,
1 minute, sir. In meanwhile, Dr. Maiti, can you start up like sharing
Load
your
your,
screen?
load your presentation. Yes, go ahead. We have,
Anirudh, can I add?
Yes, sir.
yes.
Yes, sir. Please.
Yeah, see, Anirudh, as far as value is concerned, there are two aspects. I think these instruments give us a lot of avenues for research. Like I showed you about giving Zeltrep injection and studying the perfusion. So commercially, you may not get adequate returns, but if you have passion, passion has no value.
Yes, that's important.
Correct.
No, that's what
Thank
I
you very
think. I
much.
agree with you, and that's the reason because what happened scientifically, yes, we should have, but have to make it as a practitioner viable. As I would say, as an institute, academic institute, I think it's definitely you must have it. But individual practitioner, whether it's financially viable, I think unfortunately, whether you like or not, we have to account for that. It's a practical aspect. Okay. I also have a question to
I think,
Dr.
Pramod, you buy these machines only when it is not to give a returns on practice. Basically,
So in the
you,
Yeah,
interest of
agree.
time, we'll move to the next talk.
Yeah.
yes.
Aniruddha, would you like to introduce the next speaker?
Yes. Yes. So, Dr. Aniruddha Maiti, I think, doesn't need any introduction. And we are going to listen from him the most important, the bread and butter and everything of ophthalmology. So, what is important in cataract surgery? Dr. Aniruddha, you can start.
Yeah. Thank you, Mahindrakar, for your kind words. And at the outset, I would like to thank the MOS scientific team, especially Piyush and Dr. Mahindrakar. Well, my topic is cataract surgery in patients with DR. Am I audible?
You're audible, sir.
So my topic is cataract surgery in patients with DEAR. So as we all know that a cataract and diabetic retinopathy are the leading causes to decrease in vision, and both of them actually coexist. And the incidence of cataract in diabetics is around 2 to 5 times higher than a comparable non-diabetic population. So the outcome, what is a concern, is like outcome of the cataract surgery is often guarded in diabetics. So it depends on various factors like the severity of the retinopathy, the duration of the diabetes, the glycemic control, the blood pressure control, and the concerns after the cataract surgery in diabetics are there is an accelerated progression of retinopathy. Obviously, it is higher when there is an intraoperative complication or an untreated PDR or NPDR with DME. There is a macular edema, there is early PCO, fibrinous uveitis. There is also neovascularization of the anterior segment, which develops to NVG, although it is a rare, but it is a dreadful thing. Now, we always discuss there is a progression of DEAR following cataract surgery with phacoemulsification. It has come down, but definitely there is a progression, and there are a lot of studies which says that the incidence rate is 28% in the operated eye as opposed to 14% in unoperated eye. The rate of progression is 36% as opposed to 20%. Now, what is the progression of DME after cataract surgery? We need to explain all this before planning a cataract surgery in a diabetics. Now, the poor visual outcome after cataract surgery are very strongly associated with the duration of the diabetes mellitus, the preoperative status of diabetic retinopathy, and seems to be mostly due to DME. The cataract surgery worsens the macular edema and hastens the progression of diabetic retinopathy. Now, this is very interesting. The risk of macular edema is often associated with the preoperative grade of retinopathy. If you see the risk of DME in the first year postoperatively was 1% when there is no DR preoperatively. And when it increases, when the severity of the retinopathy increases. When there's a mild NPDR preoperatively, the chances are of DME is 5.4%, and moderate is even higher, and severe it is 13.1%. Now, it is crucial to know the risk for worsening DME with cataract surgery. If you see protocol Q, the patients who had no evidence of DME and no history of treatment for DME, obviously there is a 0% chance of worsening DME. But patients at the preoperative level, if there is a non-center involved DME, there is a chance of 10% chance of developing center involving DME. Those with existing center involving DME had a chance of 12% chance of worsening DME. And a history of a treatment for DME put the patient at the greatest risk of worsening DME at the time of cataract surgery, up to 20% of those patients showing signs of worsening DME with cataract surgery. So these things we need to keep in mind. Now, what is the visual outcome in diabetic retinopathy cataract surgery? With no minimal DR or no DME at the time of cataract surgery, generally they does very well. But moderate, severe NPDR in PDR cases, there is a guarded visual prognosis. But if it is planned properly, it can give excellent results. What needs to be planned? The preoperative planning, the intraoperative evaluation, and a close postoperative supervision. If you go for the preoperative evaluation, a glued glycemic control is required. Proportionate visual loss, sometimes the cataract and the vision doesn't, the grade of the cataract and the vision doesn't match. Sometimes we need to do a RAM or PAM. We need to do a gonioscopy to rule out the NVA and NVI. Obviously, the retinal evolution is the most important. Investigation, I think all patient who is undergoing the cataract patient undergoing, diabetic patient undergoing cataract should do an OCT. Yes, fluorescent angiogram is only in those cases where the vision is not corroborating with the grade of cataract and you suspect and macular ischemia. Obviously, for this, Octa is a useful tool. And B-scan, those where the posterior segment is not visualized, we need to rule out whether it's a vitreous hemorrhage or the TRD is there. Now, pre-operative consideration is the visibility permits, assess the level of diabetic retinopathy, assess whether there is a presence of DME or not. We need to treat those. We need to treat diabetic retinopathy and DME first. And obviously, we need to use NSAIDs before surgery. Generally, the preferred practice is 3 days before the cataract surgery, the NSAIDs are started. Now, treatment of diabetic retinopathy before cataract surgery, as mentioned, we need to, if there is a focal leakage, we can do a laser. If there is PDA, high risk PDA, we have to do a PRP. Obviously, if there is central involving DME, then we need to inject anti-VEGF or a steroid before the cataract surgery. Now, what is the ideal time of PRP according to the AO guidelines in impending cataract surgery? Early laser PRP may be warranted. Partial or limited pan-retinal photocoagulation treatment is not recommended. And addition to that, if there's a CME along with the high-risk PDA, we need to combine the anti-VEGF along with the PRP. Now, what is the timing of a cataract surgery? In the mild cataract, the surgery can wait for some time. After doing a PRP, the stability is attained, and within 6 to 1 year, the cataract needs to be planned. In a severe cataract or PSC, where there's a disturbing view, the cataract surgery needs to be performed before PRP, and then pre or post-op anti-VEGF or a steroid on a PRN basis may be given for the macular edema. Now, there is a lot of guidelines for the perioperative and operative consideration. This part, I think the perioperative part will be taken care in the next talk. Obviously, phaco emulsification is the preferred choice. The large CCC and in-back placement of IL is required. Large optic hydrophobic acrylic IL is preferred over the multifocal ILs. Combined procedure has been shown to be safe and effective alternative to the sequential surgery. Now, high-risk PDA, there is a lot of times there is non-amicable to photocoagulation. So obviously, combined surgery is always better in these cases. In some patients with a severe vitreous hemorrhage or pre-retinal hemorrhage, obviously the other guidelines, like other indications of combined surgeries, are the TRD and the combined TRDs when the vitreous hemorrhage or uveitis arises. The advantage is that all the nucleus sclerosis will progress after vitrectomy, so we can do it together. Complication, if there is with the cataract surgery, sometimes are complicated. Diabetic cataracts are complicated. So if we are doing a combine, that can be resolved during the vitrectomy. Less chances of neovascular glaucoma if we do a proper pan-retinal coagulation. Intra-op completion of PRP achieved, there's a decrease in VEGF load, so there is less DME. The post-op consideration is generally the dilated fundoscopy is recommended at week 1, 4 to 6 weeks, and 3 to 4 months following cataract extraction. Now, adjuvant treatment, this is something to address the post-operative DME. Many investigators have focused on combination of phaco with adjuvant treatment. Whether it is an intravitreal anti-VEGF or steroid along with laser photocoagulation. And there are a lot of studies, we are not going through the details, but intravitreal dexamethasone plays an important role when it is combined with the cataract surgery. It prevents the formation of DME for the initial period. So this is one thing that needs to be differentiated. The pseudophakic macular edema should be differentiated from DME. If required, you can do an DFA to see the optic disc staining and the typical petaloid, which happens in the pseudophakic DME patient, pseudophakic CME patient, and differentiate from the DME. So in nutshell, as the diabetic retinopathy progresses faster after cataract surgery, so the principles of management are as follows. In the mild cataract, assess the DR status. Patient without visual loss, clear fundus view, obviously doesn't require a cataract surgery. Moderate cataract, we need to assess the status and treat the severe NPDR or the PDR with a laser PRP, DME with a focal or anti-VEGF therapy before the cataract surgery. And once the DR and DME is stable, consider the cataract surgery to improve the vision. And the last scenario, that is a severe to advanced cataract with poor fundus view, if the DR status cannot be adequately assessed, do the cataract first, followed by assessment and treat as necessary. So the take-home message, pre-existing DME prior to cataract surgery or a history of previous treatment of DME may increase the chances of DME after cataract surgery. The assessment and treatment of diabetic retinopathy or DME needs to be done prior to the cataract surgery. Adequate systemic control and treatment of diabetic retinopathy and DME with intravitreal anti-VEGF or steroid or laser has been shown to have a promising result. Thank you.
Thank you very much, Dr. Maiti. We have Professor Natarajan, who has to leave for a live surgery in Bolivia. So I would like to ask you, Dr. Natarajan, are you there?
I'm there.
So again, with regards to diabetic retinopathy, of course, surgery is difficult, whether it's posterior segment or whether it's cataract. But one untouched area is the counseling in these patients. So counseling has to be very apt and adequate in whether it's cataract surgery or whether it's retina surgery. So how do you counsel a patient with PDR who has significant cataract about the actual risk of progression in post surgery?
That's why I think I always tell controlling diabetes does not control the eye. And the second is I tell them you need a periodic follow-up, and many times, very often, if it's a PDR, not treated, never done laser before, and you have to have a cataract. I think Anirudh pointed out in those eyes, better to combine cataract with vitrectomy and do mainly because of the panretinal photocoagulation. And if there's not much of proliferation or a fibrous tissue, then you can inject the anti-VEGF at the conclusion of surgery and keep following it up. Particularly, he mentioned first week and then third week and fourth week, and then decide the further line of management.
Thank you. Thank you, Professor
Natarajan, in a one-eyed patient, how much intervention one should go for? Because we have to be conservative as well as we have to realize that this is the only eye of the patient. And there are a lot of these patients who come to us whether should we go in aggressively, we should start thinking of one-time treatment, or we think of staggered treatment.
No, I think one is how good is the patient in follow-up, and if he's one-eyed and if the other eye is lost
Good
because
follow. The patient is ready because he's one-eyed. He is ready to come every day if you want him to. But question is how much you should go at one shot. Should we go in for an intravitreal? We should go in for everything done together, vitrectomy and everything.
No. I think
do you suggest
it depends
one
on
thing?
it will depend on the status he comes to you about the amount of cataract.
Advanced cataracts. There is a PDR. There is, so how aggressive would like to go treat these patients?
Yeah, but if it is aggressive, advanced cataract with aggressive PDR, if you cannot see and if you don't treat, the risks are more than not treating. So in those patients, I think we have to remove the cataract, and if you're able to do sometimes immediately you can do the panretinal photocorrection. And I remember some eyes we have done the cataract IOL and do a panretinal on the table itself with a indirect ophthalmoscope.
I'm asking you, how aggressive? You are ready to go in for an aggressive one time, do everything. Or
yeah,
you
but,
would like to,
but if you can do the cataract,
this question is very important for the patient's point of view. One-eyed patient, if you do cataract surgery, he gets some vision. Then you start doing treatment, or you do everything together, because that's an aggressive surgery.
If it's the advanced PDR with advanced cataract, do the cataract, and if you're able to do the panretinal photocorrection on the table, that's the best. And then follow up, seeing the proliferation, and if there's a proliferation increasing in spite of the laser, you have to do the vitrectomy.
Can I add something here?
In the interest of time,
yeah. Can I add something?
Promote, yes.
Yeah, because routine cataract, like most of the cataract surgeon, being not a VR surgeon, they may not have set up in a OT to finish laser on the table.
Yes.
The other way, what you can have is, if there's new vessels or there's not much fibrosis, and particularly diabetic macular edema, which is we are more concerned about, PDR will give you some time to have a laser later on. But if you have a diabetic macular edema, what they can do is have an anti-VEGF injection on the table along with cataract surgery, which is anybody can do. Yeah. And then you have some time to buy, and within a week or so, you initiate laser. Now, advantage of that also, because you have a anti-VEGF given, effect lasts somewhere around 4 to 6 weeks. Yes. And once you are done, once you finish laser after a week or so, by the time laser takes over, again, that is around at least 3 weeks, it's 2 to 3 weeks, you start and go until 2 to 3 months. I think overlapping phase, I think things can work out well.
Great. That's what I wanted to put. Yeah.
Thank you, sir. So with this, we will move on to the next talk by our own Dr. Rajesh Joshi, editor JCOR and professor at GMC Yavatmal.
Rajesh, welcome.
Yeah, thank you so much, Dr. Piyush and MOS for this opportunity. In fact, this is a difficult topic and it is as difficult as treating any proliferative diabetic retinopathy. Nothing to disclose. Dr. Maiti's talk has made it very easy for me because most of the things he has introduced, and diabetic affects all ocular tissues, especially the retina. Cataract occurs earlier and faster in diabetics. IOL choice influences the visual quality, post-operative inflammation, and long-term outcomes. So that's why the choice of IOL is absolutely essential. And as you know, phacoemulsification is the choice of cataract surgery. And the aim of cataract surgery in patients having diabetic is to clear the media so that visualization of the retina and treatment of retinal problem is possible. Most of the surgeons, they prefer clear corneal incision, but of course it is an individual choice, and the capsulorhexis has to be in the tune of 5 to 5.5 mm. Well-centered rhexis is absolutely essential to ensure good optic overlap, because if there is a good optic overlap, there won't PCO formation is less. It prevents IOL tilt. Better centration for future retinal imaging is essential to have 5.5 millimeter of well-centered rhexis, and chop technique is which is preferred by most of the surgeons because it is quick and you don't have to spend too much of time for performing cataract surgery. And thorough cortical cleanup is absolutely essential to prevent post-op inflammation in these patients. Now, the key consideration in diabetic patients is the glycemic control, which is absolutely essential because diabetic complication and control trial has shown that if there is a tight control of diabetes, it prevents complications of diabetic retinopathy, and presence and severity of diabetic retinopathy is essential. The macular status, which in the form of diabetic macular edema and ischemia, has to be considered before operating this patient. Previous retinal lasers and intravitreal injections. You must know all these things, whether the patient has undergone with the treatment of diabetic retinopathy or diabetic macular edema or not. And risk for future vitrectomy has to be assessed before taking this patient for cataract surgery. Pupillary dilatation and zonular status has to be assessed because in intraop, if the pupil goes down, you may have to use epinephrine, and that can cause post-op macular edema. So you have to consider all these things before you take these patients for surgery. Now, why IOL choice matters? Diabetic eyes have high post-op inflammation. There is a greater risk of post-op posterior capsular opacification, higher incidence of macular edema, and future need for retinal imaging or vitrectomy. IOL must provide stability, clarity, and diagnostic use. So that's why the choice of IOL matters, and the square is IOL should be preferred because it prevents PCO formation. Now, the best IOL recommendation is monofocal in these patients. Of course, there are certain indications for other IOLs as well, which I will come shortly. The advantages of the monofocal IOL is excellent contrast sensitivity, because these patients who are having diabetic retinopathy, they have reduced contrast sensitivity, which could be due to the macular edema or the laser which has been done previously. The best quality of retinal image is obtained by monofocal IOL. There is no dysphotopsia, more suitable when macular status is uncertain, allows easy retinal treatment later on. It is affordable and reliable as well. The most preferred material is hydrophobic because of less post-op inflammation, less posterior capsular opacification occurrence, better long-term clarity, good biocompatibility. When not to use premium IOLs, any level of diabetic macular edema, moderate to severe NPDR or proliferative diabetic retinopathy, patients who have undergone laser previously or they have undergone anti-VEGF injections, there is suspected macular edema. Patients may need future vitrectomy. There is a poor contrast sensitivity and irregular pupil or zonal weakness, because otherwise also these are contraindications for using premium IOLs. EDOF lenses used with caution may be considered only if there is no diabetic retinopathy, there is no macular disease, excellent glycemic control, patient understands the limitations of these IOLs and prefer non-refractive EDOF IOL at all you want to use EDOF lenses. Multifocal IOLs should best be avoided and they should be used cautiously, and patient must understand the limitations of these IOLs. Because the multifocal IOLs reduce the contrast sensitivity, they increase the glare and halos, retinal pathology, there is a poor visualization in these patients, difficult retinal evaluation due to ring artifacts, and they may complicate vitrectomy visualization. Of course, I'm not aware of this thing. You all who are vitreoretinal surgeon, they can comment on this vitrectomy, complicate during vitrectomy visualization or not. I'm not sure about this. Toric IOLs in diabetics use toric IOLs only if the macula is healthy. There is no significant diabetic retinopathy. Patients, they are reliable for follow-up and avoid in patients who are having poor pupillary dilatation, zonal weakness, and it is best to avoid limbal relaxing incision in if the patient has got astigmatism, because the diabetic itself delays wound healing and chances of wound infection and dry is more in these patients. So take home points are retina first, IOL next. Always evaluate and stabilize diabetic retinopathy and macular edema before choosing an IOL. Monofocal hydrophobic IOL is the best choice. Avoid premium IOLs in these patients. Toric IOLs are safe, but only if macula is healthy. Always do pre-op OCT in these patients. Post-op NSAIDs and OCT monitoring are essential. Hydrophilic IOLs should be avoided. And future vitrectomy choice, simple, stable optics should be preferred. Prefer monofocal, hydrophobic, acrylic three-piece if zonals are weak.
Thank you very
Thanks for your
much.
patience listening.
Thank you very much, sir. I think this was a very nice and comprehensive talk. Just to clarify on those 2 points that you mentioned, with regards to difficulty during vitrectomy in patients with multifocal IOL, I have never faced any difficulty, and neither are most of my colleagues. They've never faced any difficulty with these kind of IOLs. The second point is it's extremely important to remember these toric IOLs. You have to be very careful while implanting them with patients who have active edema. So what happens is, or have had edema in the past and there are macular changes, because that is going to come out, give the same effect of as a irregular astigmatism. So when you put in a toric implant in these situations, that can make matters difficult. Now, do we have Dr. Sharad Bhumad sir there?
Yeah, I'm there.
Sir, I have a question for you, sir. Now, in say early or a stable NPDR, a mild to moderate NPDR, which is stable for quite some time, are multifocals or EDOFs truly contraindicated, or is it just a case-by-case decision?
It's not truly contraindicated. If the macula is healthy and the retinopathy is very mild, there is no contraindication.
Dr. Manoj Sasude, sir, any opinion on that, sir?
See, the way the Rajesh sir has covered very well why we are concerned about these lenses in diabetic specifically. We don't consider in other things. Even multifocals in a normal patient also we think several times before implanting. The same thing increases in cases of the diabetic retinopathy. If it is a pre-existing disease, then you know that what will be the natural course of the disease. It is a always naturally progressive disorder, chronic progressive disorder. So today, if it is stable, doesn't mean that next year already it has been shown its manifestation stage, maybe mild, moderate form. So it is better to avoid it because of the light sensitivity and contrast sensitivity are there, and photopsia issues are there. And patient later on, it goes to someone else, to your colleagues itself, then he will be blaming you that unnecessarily you have been put multifocal lens, which was relatively contraindicated, not absolute contraindication, but relative contraindication was there. So all those things should be kept in mind.
I think one small point I would like to put in that if you have treated diabetic retinopathy properly and the macular edema has been taken care and you're taken care of peripheral neovascularization and everything, I don't think that's an absolute contraindication for a multifocal.
So there is no
one has to be very pragmatic because the patients are demanding nowadays.
Yes.
If we do not put a multifocal, somebody will say, why did you not do it when your retina is all right now? You have been treated. You have been, there's no macular edema. Your macular contour is normal. Your macular functions are normal. And if you don't still do it, probably I would like to err that I'll give your patient a choice. You have a choice of a multifocal and you have this with its side effects. Because this neuroadaptation has taken care of the newer multifocals, the EPOC lenses and the Zeiss lenses. I mean, they are very good. I'm finding them very good post-operative.
So all those watching. So one second, sir. All those watching, we'll quickly move on. We'll just take Dr. Pramod Bhinde's take on this. But before that, for all those watching, what you've seen is three retina surgeons having three contrasting views right now. So please,
Yeah, yeah.
you have to
It's
take it.
good.
You have to take it with a
Retina.
pinch of salt. Diabetic retinopathy is a completely different ball game. I personally would never ever put a multifocal or even a need-off in a patient who has had PDR in the past or has had DME in the past. This question was specifically for patients who are in early stages or have had stable NPDR for quite some time. You've been following them up, and you know that they're well controlled, because all of us have patients who had diabetic retinopathy, who have diabetes for 20 years, and they've they've not gone beyond mild NPDR. So whether we should deny those patients or not, that was the question. Pramod Bhinde sir, if you can give your opinion and we move on to the next talk.
Yeah, I think it's a difficult
Dr.
question
Sarang,
to
can you
answer,
conclude?
because what you rightly mentioned scenario and what Dr. Prashant sir is telling and what Dr. Manoj said, there is no absolute contraindication. But given option, and because it's a chronic disease and long term, we never know. Sometimes it's a matter of time. He's going to have some other manifestations that we all know down the line, 10 years, 15 years. Okay. So tell him advantages of both, disadvantages of both. If personally, I would prefer monofocal. Given option, I personally would monofocal. If patient insists on, I will tell him these are the sighting, and in future, right now it is okay, but future you will end up in these situations. So, and then you take a call. But yes, not absolute contraindication, but relative. Now, coming back, what first question, yes, because we all got used to dealing with and handling doing vitrectomy in a multifocal IOL, and we got used to it handling that parallax what you get. But definitely, it is not as smooth as doing in a monofocal lenses and you are doing vitrectomy, particularly when you have a vitrectomy is okay, but membrane peeling, and when you come to dealing with a membrane dissection, those circular rings definitely create a parallax. You have to be very, very cautious with that, and when can easily you miss the plane. And particularly you have associated posterior capsule opacification or something. So I think that adds on later on, and probably adding to that, again, I'll try my best to convince patient for monofocal.
Yes, correct.
Thank you. Thank you very much, sir. With this, we move on to the next speaker. I invite Dr. Sarang Lambert to present his talk on intravitreal therapy across the diabetic retinopathy spectrum.
Yeah, good evening, everyone. Are my slides visible?
You have to just go into full screen mode.
I hope they are visible and I am audible.
Yes, sir.
Yes, yes.
Oh, great, great. So they were very nice talks, and let's quickly move on to going for the intravitreal therapy across the diabetic retinopathy spectrum, because day in, day out, we are constantly dealing with some bleeding happening in the macular area or in the periphery. So what are the deciding features where you would like to go for laser treatment or injections? Is the central subfield thickness. So what is the central subfield? Is the central these three ETDRS rings, for the central one being the 1 millimeter, the second ring being 3 millimeters, and the outer one being 6 millimeters. So whatever is involving the central 1 millimeter area, these are the color coding, and if it goes beyond 300 microns, then these patients are classified into center involving macular edema, and whatever is not involving the center are the non-center involving. So currently these are the two ways we would like to classify a maculopathy, and depending on this we have almost like 4 situations, and the fifth one being preparatory avastin before partial vitrectomy. So first situation is a non-center involving diabetic macular edema, where the central subfield thickness is normal and the focal thickness is less than 400 microns. So this is an example of such a situation where we have the central subfield thickness which is normal in this case, and the thickness in the focal thickness in the specific area is less than 400 microns. So such patients we can easily go ahead with grid laser and eventually they do well. Second situation is a non-center involving diabetic macular edema where the central subfield thickness is normal, but the focal thickness is more than 400 microns. So especially in such situations where the thickness is more than 400 microns, the laser doesn't act so well. So in these situations, you first give the anti-VEGF course followed by whenever the macular edema reduces, then you can easily do macular laser, and that takes care of the situation. Third situation is a center involving diabetic macular edema with a central subfield thickness which is less than 300 microns or somewhere close by, and the visual acuity is good. So especially in such cases, you can counsel the patient that you can undergo an observation and you can strictly control your systemic parameters, especially being the uncontrolled blood sugar levels, and especially if he is hypertensive, you can control the hypertension. And in these situations, rarely you can advise focal laser to some aneurysms which are close by to the fovea. And these are the post-op photographs which tell you that even in such situations, laser, doing some minimal amount of laser might work. Another situation which is a central involving diabetic macular edema with a central subfield thickness more than 300 microns and visual acuity worse than 6/9. So probably we do encounter such kind of situations mostly in India, especially the patients not taking good care of themselves, and even there is a poor referral from the physician side. So in such situations, we need to do a therapeutic intervention, and we have various anti-VEGF agents as well as steroids at our disposal. So this was one of our case, 56-year-old male who came all the way from Calcutta, and his best corrected visual acuity was 6/18, and I think the left eye it's not showing up. But even and you can see on the fluorescein angiogram there is diffuse amount of leakage. The fundus picture also shows you that he's having that retinopathy since many months, and this is how the macula looks. The central subfield thickness in both eyes is more than 300 microns, and we generally do comfortably use a lot of steroids, especially in diabetic patients, since we have a excellent backup of glaucoma department. And this patient did undergo anti-VEGF injections for plus steroids followed by PRP and macular laser, and you can see an excellent response just to few injections and some amount of laser being done for this patient. And you can see the visual acuity has improved so nicely, and the foveal architecture is reasonably looking very good. But unfortunately this patient didn't follow up with us properly, and he did land up with significant elevated IOP, and he did require trabeculectomy for that. These are few other examples where very bad looking maculas you can take care with the help of combination of treatment. So that's how we go about, especially even in these cases, that even a minimal amount of improvement gives some chance for the patient to manage his day-to-day activities. This is another case where it was a very badly looking macula, and we did some anti-VEGF steroids and some amount of laser, and you can see how nicely the foveal contour is showing up, though you can very well see that the foveal photoreceptor loss is quite significant. And but still you can see these kind of labeled untreatable patients do also develop a good foveal architecture, especially after treatment with steroid combination. Another important way to highlight is that even if patients you are doing PRP and just telling them that probably the PRP is going to take care of most of the stuff, even a good looking foveas, eventually these patients, if they don't follow up at a regular interval, they may land up with such kind of a situation, as you can see in future OCTs, where the macula is not looking so good, and eventually he did require vitrectomy for the right eye and further injections for the left eye. And at baseline to start with, he had very good vision, but eventually he lost vision because he didn't come properly for follow-up. So follow-up and dosing schedules has to be nicely offered to the patient and has to be discussed threadbare. Many times the patients, the chair time is more so to explain to the patient what sort of treatment option he has and what sort of follow-up he has to stick to. And we initially the studies told have shown us that fixed dose combinations give the best possible results, but there is a huge burden of injections and follow-up on the patient. So a PRN is somewhere where the patient, whenever he comes for a follow-up and the macular edema is detected at that time, you would like to inject. But somewhere in between, treat and extend probably works quite well, and that has to be shown. That has been shown to be much more effective than the PRN or the fixed combination with balance of both the things. So just a brief mention about why do we require repeated treatment. So basically we need to know the pharmacodynamics and the pharmacokinetics. Dynamics of injection are neutralizing the VEGF-A antibodies or the receptor blockade, creating decoy receptors or angiotensin 2 inhibition. So this is a very important concept, that whenever we are pushing anti-VEGF into the vitreous cavity, there are three things happening. One is it's taking care of the free floating VEGF, which is there in the vitreous. It is also tackling the daily VEGF release, and there is also vitreous clearance which is happening. So whenever these things are happening, there is a specific half-life for the anti-VEGF molecule, there is a binding affinity, and there is a huge amount of molar concentration which has a huge bearing on the pharmacokinetics. So if you understand this and you are able to tackle and explain to the patient properly, then the patient may get convinced about how exactly the drug is going to act, and he has to follow up and take further injections. Brolucizumab, the newer molecule, and faricimab have really promising results, especially brolucizumab, wherein a huge amount of molar concentration you can push in the eye with the same amount of molecule injected. There are multiple. This is one of the example. She received multiple injections, and you can see until we injected her with a very good combination like a brolucizumab plus an Ozurdex. At that time, she was able to have a good visual acuity, and even the fovea is looking much better, as you can see in the photographs. Another case who underwent Ozurdex along with the cataract surgery, you can see how nicely the fovea has come back to almost looking normal, but there is a recurrence. So essentially you have to explain to the patient that you have to get treated, you have to come for a follow-up. And last but not the least, which we have regularly been doing, that this is a very bad looking diabetic retinopathy with significant proliferation, and we give anti-VEGF injections just to calm down the aggressive vessels and proliferations, and eventually you are able to do a fair enough job and bring back the macula much more in an acceptable looking retina and macula. So to summarize, imaging is very essential to determine what sort of treatment you are going to offer to the patient, and you need to choose treatment based on the evidence. Follow-ups, you have to emphasize, they are very critical, and you have to explain to the patient that multiple injections and multiple follow-ups will be required to stabilize the disease as a long term. Thank you, and I acknowledge my residents who have helped me out digging out all these patients. Thank you all very much for a patient listening.
Thank you very much, Dr. Saram but for this very comprehensive coverage. It was a tough topic to cover in such a short duration of time. Can I ask a question to Dr. Harish Asnani, sir? Are you there?
Yeah.
So these extended interval regimens that are being spoken of a lot, do you think they're actually reliable reliable, or do the patients still require closer monitoring in DME cases?
Frankly, in my practice, whenever I've attempted extended regimes, many a times I've ended up doing PRN treatment.
Yeah.
So in practice, I found it very difficult to stick to these extended regimes.
Anybody has another opinion on the same question?
No, I think that's fine.
Harish sir, also, are you also using steroids, or you are using only anti-VEGFs, and any particular choice?
No, I also use steroids because I think the importance of steroids has already been shown by a speaker here, and I think it's very important, especially in diabetic maculopathy management.
So you use it in a single syringe, both anti-VEGF and steroids, or separate, or only steroid?
No, I don't combine injections. I would give them maybe combine it with the whole therapy of giving at least 1 or 2 anti-VEGF and then giving a steroid in between and then again continuing with the anti-VEGF.
I think steroids have to be used when there is a refractive edema. You try anti-VEGFs, anti-VEGFs have not worked, and you have tried and change the anti-VEGF also. At that time, I think I go for steroid as a last resort, because
Yeah,
that
that's true.
that gives me
Not
a
for all cases.
I
It's
think
only for
now
those tough cases.
I think now we have this the new anti-VEGFs. So before going for the steroids,
long term.
yeah,
Yes,
long
Yeah.
you can use the aflibercept and faricimab before moving on to the steroids.
Dr. Kopikar, do you when you look at the OCT, is there any particular phenotype, or is there any particular type of edema that which gives you some clarity in your mind that okay, this one is going to require steroids, this one is not?
Basically, all these patients whom we have seen, also all these OCTs, I think you have to always look into their kidney function. And the macular ischemia is also a marker for nephropathy. The renal retinal syndrome is well known, but I find that there is a lot of under reporting of the kidney problem. And most of these gross pictures which you saw, they indicate a very poor control either from the past or even presently when they have taken the pictures. So all that has to be addressed. This is one thing which is very important. And most of the times I find that is not being given as much emphasis. That is
Yeah.
my comment. That's all.
Thank you. Thank you very much, sir. So with this, we'll move on to the most difficult topic of the webinar. It is when the game gets tough. And of course, we all know retinal surgery and advanced PDR these are very challenging situations. So may I invite teacher of teachers, Dr. Pramod Bhende, sir, to please share his talk.
Yeah, I hope it's visible.
Yes, sir.
Yeah, so basically, thanks, Dr. Piyush and MOS for having me here. I mean, I think I really enjoyed wonderful talks. Yes, and I just re-emphasize that what I told about Dr. Hemang, renal parameters control, because even macular edema, I have a renal parameter derange. I won't treat these eyes. I will wait for a while, send them to nephrologist, and once things are settled down, quite some time macular edema settles down on its own. So, I mean, we have seen these cases. I think that's a very, very important issue before going ahead with just anti-VEGF every case. And now again, we have evidence that anti-VEGF do have issue about nephropathy can worsen further. So nowadays we started asking, particularly, obviously, if there is a CKD history there, ask nephrologist clearance, that become a mandatory because enough evidence we have. I think that just wanted to add there. Just coming to the talk, basically, complex retinal detachments, coming to management. Really, there's nothing fixed definition what is meant by complex. What we look at as a practical aspect of having been associated with angle or iris neovascularization, have a visa media opacity, non-dilating pupil, extensive very florid proliferation, no PVD, thin mobile retina or combined detachment associated with hemorrhage and the reproliferation following vitrectomy, and recurrent bleed with a anti-hyaloid proliferation or sclerotomy related proliferation. I'm not going to go all these scenarios will cover basically. So like most important is difficult visualization, and most of these eyes, we do know that the pupil sometimes doesn't dilate. We can try intracameral adrenaline, iris retractor. As far as possible, we want to avoid because they can have iris neovascularization, can have a intra bleeding and can compromise your visibility in fact, and obviously increase inflammation post-operative period. And wide angle visualization system does help. We'll just little bit later, we'll come to that. IOL and with a posterior capsular opacity reduction, we deal with day in and day out most of the time. And easiest way to deal with this, you can just create a central opening in a posterior capsule and we manage it. Very rarely we need to remove the IOL. And cataract, we already discussed extensively. I'm not going to go that part. So what things we can look at it, particularly dealing with a very extensive proliferation, use of anti-VEGFs preoperatively, good weaving system, one by one I'll come to that, correct plane for dissections, prefer periphery to center dissection most of the time, but again, it goes case based. And obviously isolated islands, small areas, attachments to take care of first and followed by, then you have a large, broad other end polyps. So this is one of the case where extensive proliferation, if you see here, we give anti-VEGF and then look at this polyp, absolutely avascular area, and take them for surgery. Surgery become much easier. This is another case, has a huge florid proliferation. Post-surgery, post-anti-VEGF, look at this picture. Surgery become almost practically but bloodless. And this was a post-operative picture, 6 weeks. central macula is quite well attached. Why I'm talking about, like, again, wide angle visualization. This is the pupil, what you saw, and now this is the view, particularly when you compare with the previous lander system and with now biome or recite, almost entire retina you can see with maybe 3 millimeter pupillary size. And added advantage what you have is with the hazy media or fluid air exchange when you're doing in a phakic eyes, particularly, that lot of recklesses you get, those are also very well handled, or rather you still can have excellent view when you use this wide angle visual system. And I think that become essential part for all of us now while doing all vitrectomy. Of course, 4-port vitrectomy, certain, as you see this proliferation, extensive proliferation, you plan well in advance, but where to put a chandelier when you're dealing with a 4-port, basically, I generally decide that pre-operatively and plan from where I'm going to initiate the dissection. So somewhere if I initiate dissection at 12 o'clock area, I would put it at 12 o'clock. I'm initiate dissection somewhere somewhere on a periphery or inferiorly or temporal or nasal side, it goes down inferiorly. The reason being, when you lift the polyp, the light illumination which falls exactly at the base and where it gives an excellent view for you dissecting the membrane, rather dissecting attachments there. Otherwise, what happened, lifted membrane and you have a light on opposite side, that shadow which cast probably, in fact, compromise your visibility. So choose where you want to the light pipe. There is no fixed ideal location, but where you would like to initiate discussion. So have a proper pre-surgery evaluation before fixing the chandelier. So now identifying clear plane is extremely important, and vitreous chysis or second membrane, what you call is, this is not a visible edge or plane. What you need to look at it with something beyond this, and that's what your right plane. Exactly here also, this is not the membrane edge of your dissection. So what is going on? A thin membrane, posterior second membrane of the vitreous going along the far reaching periphery, and it's important to identify that glistening membrane, lift it up, and then that's way, once you have that, get separated, and then you get a cleavage plane underneath. And once you are at the right plane, your surgery become very, very easy. We have this another case where start from posterior highlight, no PVD, and then again is vitrectomy. Your cutter will not give you a plane. So either you use a MVR or you use just our straight disposable needle to slice to this membrane. Use that as an initial dissection. And once you have this opening made, either you continue some part of it, and otherwise you can start either using scissor or forceps or cutter, which you feel depending on associated attachment. Here you still have attachment here, so I had a difficulty using cutter. I could lift it on the disc, but what you see here now, on its own, it is spreading beyond. Unfortunately, I could lift the entire posterior highlight only with this blade, and once it is separated from the retina, you have a cleavage plane, things become much easier. Now, classically, we all talk about membrane surgery, segmentation, delamination, but what you really, in a true sense, you do it is now, it's a combination of everything in a given case. Partly you say delaminate, this is partly you segment here, again go back and forth and back and forth. It's always a sort of combination of everything rather than only isolated segmentation or only delamination. So this is just wanted to do with the MIVS and port optimization. I got two parallel cases, similar looking cases where you use scissor here and when you use a cutter, exactly doing same job. Now you do not need high speed cutter here. In fact, you cut down the cutter speed significantly. So using as an automated scissor, exactly each isolated nail, you can snip it off here. And as you see the scissor here parallelly running two videos, same function you can use with a 25, and now we are using 27 gauge cutter. So cutter can be used as a spatula, as a scissor, as a pick, as a forceps, doing more or less same job. When in most of the cases, I would say, this is another case. Young 18-year-old female had a known diabetic since the age of 4 years, bilateral involvement. And this is a post anti-VEGF picture. She was first MBBS student when she came to us, and chandelier is here, inferior-temporal quadrant. And as you start peeling it, you gently lift it. This is again post anti-VEGF. You see, practically is almost avascular. Now, cutter is being used partly to lift the polyp from the retina, partly blunt dissection. And when you see this isolate point here, then just activate cutter. Here, cutter speed was 100 cuts per minute. So it's just about acting really as a scissor and pick, and gently you tap it. Sometimes push the retina back and it separates on its own. So basically, when you talk about a broad polyp like this, it's true sense, it is not really broad polyp. You have multiple attachment close to each other, and if you have a right plane, surgery is practically bloodless in this scenario, and you easily come out. And this is her both the eyes intervened similar way. At 3 years follow-up, she is meeting 612 and 6/9 vision. Recently, I got to know she has finished her final MBBS clear that way. Coming again, this new cutters, what we are using again with a bevel, we can shave as a so-called lawn mower technique. These are two cases. You see here flat polyps and really firmly adherent to the retina. And there's practically no separation, no elevation. And here you just go like a lawn, like a shaving technique, smoothly goes under between membrane and polyp, and keep on shaving it off, like one row, second row, third row, typically what do in lawn mowing. And that's a typical exactly word used lawn mower technique. So with and probably 27 gauge cutter, I would say much better with this. Again, though I use this 20K here and 10K here, it really doesn't matter here, because here I am not using a speed. Where I'm using is a like a less cut rate, less suction, and but only shaving mode or not even cutting mode basically. So basically close configure like a this one. So this is another case. Probably this one is easier because retina is elevated sometime, and when you elevated retina you deal with, you have one mountains and valleys. So definitely you get a cleavage plane in this type of cases compared to previous case, and you lift it easily, and this comes out much easier. But again, and I'm not sure how anti-VEGF, not only probably I feel reduce the vascularity, but probably it helps to some separation as well. So maybe it is because of better visibility, less bleeding, or it actually separates the polyp from the retina and makes life as easier. I'm not sure about that, but yes, it does help. Things become much easier, and so it's coming out practically bloodless surgery when you use this one, like anti-VEGF for these surgeries. So we're coming to combined detachments. The difference is here is there is no compromise here. Once you have a break, you need to relieve all the tractions. So all the membranes need to be renewed. And once the membranes are renewed, it's behaving like a regbatinous detachment. So fluid direction, SRF drainage, and laser and internal tamponade. However, if you have a peripheral retina is involved, where probably you may not be relieve complete traction, or if you try to attempt removal membrane there and you feel that I may land up creating compromising break, or I may need to sacrifice lens. So rather than sacrificing lens, I would support that area with either segmental buccal or encirclage to take care of traction rather than having lens, because most of these places lens is necessary. These are generally young diabetics. Accommodation is equally important for these eyes. And with a patient making aphakic, again, there are issues about agar and iris neovascularization, and definitely quality overall we talk about when you're having a phakic versus aphakic. Definitely I would give option. And what we have considered, a lot of people are having a fear about anti-secondary ischemia because of having a encirclage. But unless you really tighten the buccal too much, that fear, I don't think it is there. I think is overestimated rather than actually happening. Also, surgery become little bit difficult in these eyes because there is retina is mobile, so there is no counter traction. And when you are inducing PVD, as you see here, you try to lift it up, whole retina is getting lifted up. So you use a suction, lift it up, and at the same time, what I am doing is using my light pipe to hold the retina back. So it's a bimanual, but only 3 ports. So light pipe hold retina back and gently lift this posterior hyaloid along this area. Once you lift, cut that area to minimize avoid the risk of transmitted traction. So what we do in a PVR cases or a regular bacular hole or EMR cases, you want to detach the posterior hyaloid and then start cutting it up. Here you go clock hour by clock hour, trying separate, cut this, trying separate, cut this, and then way you go all around separating it. And once that is done, then you come back to the central part where you have this posterior polyp, and definitely you need a bimanual dissection here. And this is an area, what I would say, when you have mobile retina, scissors still have a value. It's not like that with a 20 gauge, 25 or 27 gauge cutter and bevel cutter, I can do everything. They still have, because it sucks and cuts and you still have some amount of uncontrolled activity, but scissors have a best control. So these are the typical cases I would use still definitely. Scissors are indicated in this type of scenario. And of course, here you start dissection from center to the periphery. Here, because disc as the fulcrum, posterior retina is relatively thicker, less ischemic. So chances of creating iotromic break is much less when you go center to the periphery. Yes, there is some risk of bleeding in this, more risk compared to when you start periphery towards center. But I think this is a better way of dealing with when you are dealing with combined retinal detachment. And subsequently, as I said, this is one case where peripheral probably just segmental buccali added. Patient is holding on very well. And all other steps like a regmato is determined, you do it. So to conclude, TRD and CRD are nowadays the most common indications for PDR surgery. It may develop during active or late stage and PRD, particularly cicatricial stage. Modern surgical techniques does allow to be used not only as a cutter, but also as a forceps or a pick, reducing the need for ancillary instruments. Biomillennial surgery facilitates more aggressive membrane dissections. Pre-op anti-VEGFs definitely help to minimize intra-op bleeding and to achieve complete removal, leading to overall better anatomical success. But final visual outcome obviously depends on macular status, how the ischemia is. So thank you very much once again, Piyush and MOS for having me here.
Thank you.
Thank you, sir.
Thank you very much, sir, for this masterclass and this gamut of such important pearls that we will, it'll help us improve our surgeries as well. So one question that I had was that in cases of, say, recurrent vitreous hemorrhage after following a complete vitrectomy, any steps that you would advise to be done differently in the resurgery?
Yeah, there are two things. First thing I would like to know, need to differentiate between whether it is recurrent hemorrhage or persistent hemorrhage. Now, if it is on the table, you have left large blood clot. Obviously, early post-operative period, you have a diffuse hem. Sometimes you have a peripheral vitreous cut. There are some vitreous, there are blood trapped in this here that you know at the end of surgery. And you have a diffuse hem subsequently post-operative period. And when patient comes back and he said, in between, I never had a clear vision, but over a period of time, it is clearing. So I know I'm dealing with a persistent hem. I would do serial ultrasonography, and if retina is attached, I would prefer to wait and watch. Now, patient had a clear vitreous cavity, had a good vision, and then he comes back with a sudden drop in our vision. Somewhere it happens generally a window between 4 and 6 weeks. That is a reason when you have a scar contraction or inflammatory cascade, when you look at those areas, new proliferation, new vessels proliferate. That is a window. So what I would do is obviously is ultrasonography to assess the retina. And all these cases, my protocol is I get UBM done to look for a like anterior hyaloid proliferation and proliferation at the sclerotomy site. Okay. Of course, retina is attached, you definitely going to go in. Retina if it is detached, or if again reproliferation, retina is pulled up with retractional or regmatic. But if there is anterior hyaloid proliferation, now previously what I used to do is definitely go in, clear that proliferation, and do additional laser. Now, if I have operated the case, I know, look at the previous notes, and I have done good extensive laser. So, and if history is just only 2 or 3 weeks, and you have already the on UBM says shows no proliferation at the anterior no sclerotomy site or anterior proliferation, I give a chance, I wait some more time. Generally, I tell them come after 2 to 3 weeks, and if patient is improving, then continue follow. If proliferation is there, peripheral proliferation, you can add on anti-VEGF, you can add on ARC. Those are the ways. And with that also, if you want to wait and then reassess again after 3 to 4 weeks, blood clears, fine. Otherwise, go in.
Thank you, sir.
Sir, one question.
Pramod, can I have a question?
Yes, sir.
Do you aggressively go for an ILM in all cases?
Well, diabetics, I remove ILM only if there is associated macular hole. But most of the time,
if there is a macular edema,
yeah,
it's
no,
recurrent or resistant edema,
I
go for it. Remove this ILM also.
no, I do not go for.
You were there. You are doing everything, and it has been shown that ILM removal reduces the persistent edema.
Well, this is a contra. Like again, you have a literature supporting both the sides. Yeah. And most of these diabetic vitrectomy cases, part of traction also is involved in that. And when you have a traction relieves, even quite sometimes you relieve the traction, and even macular hole without ILM peeling, it closes. That is one thing. But if you have a macular membrane, premacular membrane or ERM, when you remove and probably you put tryphon blue, or brilliant blue or VBG, quite sometime part of ILM would have come out along with that.
True.
Okay, but proactively, I do not go behind ILM in most of the cases, because particularly when you're having a chronic CME, cystoid edema particularly, peeling ILM, sometimes you may land up even creating a macular hole right on the table.
Okay.
And peeling is probably is not as easy as we do in a macular hole, because macula is spongy. And sometimes you try to peel it off, you just it's really not that easy that way compared to macular hole. I mean, that is my personal thing. I know a lot of people they do, but personally I do not go for that.
Sir, I would like to ask Dr. Sharad Bhumaj sir and Dr. Manoj Saswade sir, that in your experience, have you or what have you come to believe that whether early vitrectomy for non-clearing teams they lead to a better functional outcome, or do you think as compared to say delayed intervention, which we've traditionally been doing?
Traditionally, we were told or taught to wait for 2 months, 3 months, and then to consider for the vitrectomy. Nowadays, because of the anti-VEGFs particularly, and second thing is the vitrectomy system itself, the results are highly predictive. So it was not the time which we have seen that 800 cut rate with ST2 and 20 gauge vitrectomy, and the vitrectomy itself was having some inherent complication rates more than what we are seeing today nowadays. So it is better to advise early vitrectomy if patient is one-eyed or wants to early rehabilitation for the vision. Then it is a very safe tool for the clearing the vitreous hemorrhage, in my opinion. And
So how long would you wait, sir?
You remove the ARMs also. How long it depends upon the when the patient has presented to, whether it was a neglected case or already under treatment. If he has already undergone the laser treatments or anti-VEGFs, then in such cases you can wait for a longer time. If it is not taken care previously by any retina surgeon, then it is always advisable to go for the early surgery.
I would add young diabetics in that list also, what Manoj said.
Yes, young diabetics. Yes.
Yes.
Dr. Sharad Bhumaj, are you there, sir?
Yeah. So any eye which has not undergone PRP laser, there the window of observation should be less, and we should try to go in much earlier if the vitreous hemorrhage is not clearing. If it is, you have seen the case earlier, and if the diabetic retinopathy is stable, well lasered, and if the other eye is having good vision, you have the option of prolonged waiting.
Perfect, sir.
Yeah.
So I think this is a topic that we can just go on, and we've overshot by 15 minutes. Dr. Aniruddha, do you have any questions that you would like to quickly ask before we close the session?
Yeah, only one question, like what should we tell the general doctors who are practicing with minimum setup, like in smaller towns, that when should they treat and when they should stop treating and refer to a retina specialist? Is there any one or two tips that you will like to give the panelists, the speakers, quickly? Yeah. Pramod sir, you will like to say anything?
So basically, general ophthalmologists, now all the ophthalmologists, they know how to do good indirect ophthalmoscopy. There was a time when we all learn only with a direct ophthalmoscope. I think any changes of diabetic retinopathy, I think they should have a session to a retina specialist. Subsequent follow-up, whether they need treatment or not, let diabetologist, a better retina specialist take care of. But I think every ophthalmologist, particularly with a non-diabetic patient, should examine the fundus. If no retinopathy, obviously that's okay, then they can continue follow. But you have early any sign of retinopathy, I would say they should.
I think the teleophthalmology also has a big role in this. Peripheral patients can be referred to a center because early detection gives you better results at any time.
Diabetic
Bigger cities, Asnani sir or Kopikar sir, you will like to suggest anything like Mumbai, bigger cities?
I think in not even bigger, all the cities, I think most of the general ophthalmology practices do have an OCT also. So I think good indirect and an OCT would go a long way in identifying cases of diabetic retinopathy and maculopathy. And as Pramod also said, that moment you detect any retinopathy or any evidence of maculopathy, please refer to a retina specialist.
So I think that is very important point from medical legal point of view also, that proper consultations and proper diagnosis and investigation should be done. I think Dr. Piyush, we can take further.
So I
and
would just like to give my opinion also. I would agree with PB sir and Harish sir regarding the same, the moment you have. But the reason I say that is that in my weekly practice, at least 3 to 4 times, I get a patient reference for patient has moderate NPDR, but after I examine the patient, inevitably there are quite a few NVs, and in certain cases NVD is also very flourishing there. So even though people are getting better, I think it's better to refer the moment you see mild moderate changes as well. So thank you everyone.
Thank you, everyone. Thank you
Thank
so
you.
much.
Thank you
I
so
would like
much.
to thank all the expert panel, Dr. Prashant Agnihotri sir, Dr. Harish Asnani, Dr. Natarajan, Dr. Manu Sasavade, Dr. Sharad Bhuma sir, Dr. Hemang Kopikar sir, all the wonderful speakers, Dr. Vatsal Parekh, Dr. Divyansh Mishra, Dr. Anil Maiti, Dr. Rajesh Joshi, Dr. Sarang Lambat, and of course, Dr. Pramod Bende for sharing all the time and all these lovely points. I'd like to thank Dr. Anindra Mahindrakar for curating the session along with me. I would like to thank Entode for their support, and of course Sunilji from Zadneotech for the seamless tech
It was
support.
an excellent present. Absolutely.
Thank you so much. Very
Thanks,
seamless it
everyone.
was.
Everyone, wherever you are, have
Thank
a
you.
good night.
And advance New Year wishes. Let me tell now itself.